Okay, well, it's 12:05. Welcome to the UCCS Speaker Series. I'm Richard Kravitz, Director here at the Center. And this is the second talk of the academic year 2021-22, continuing with our annual theme of emerging from the pandemic, promoting health and prosperity for all Californians in the wake of COVID-19. So for those of you who were here at last week's talk, I apologize because I'm going to repeat myself. But I do want to briefly introduce UCCS to those of you who are less familiar with it. We are the diplomatic mission for the University of California in Sacramento, and we have two principal goals: to prepare the next generation of California's future leaders through experiential learning, internships, and academic programs in Sacramento, and to share solid expert knowledge with policymakers in the interest of enhancing public policy for the benefit of all Californians. But what we share and how we share it really depends on you, our audience. And that's why this is a kind of special plea to all of you, that if there's topics we're missing or faculty speakers you'd like to hear from, please let us know. If you work in state government and suspect UC must have an expert on that topic, but don't know how to get started, please let us know. And just in general, we want to be your partners in connecting you to the subject matter expertise you need to make the best possible decisions in the interest of public policy. So now to today's topic, which is equity and effectiveness in California's COVID response. California, as many of you know, now has the lowest COVID infection rate in the nation, though it's still plenty high and much higher than the nadir just several months ago, but it's not always been this way. Last winter, the state was hit very hard, and the impact was not evenly distributed. So here to talk about both the effectiveness of California's response over time, as well as some of the disparate impacts of COVID on vulnerable populations, is Kirsten Bibbins-Domingo. Dr. Bibbins-Domingo is professor and chair of the Department of Epidemiology and Biostatistics and the Lee Goldman Endowed Chair and Professor of Medicine at the University of California, San Francisco. She's also inaugural Vice Dean for Population Health and Health Equity at the UCSF School of Medicine and co-founder of the UCSF Center for Vulnerable Populations at Zuckerberg San Francisco General Hospital. Dr. Bibbins-Domingo is the author of a multitude of original research papers focusing on preventive medicine in the US and internationally, and has received many awards for her work. An elected member of the National Academy of Medicine, she also served on and for 3 years chaired the U.S. Preventive Services Task Force. So before we get started with our speaker, I'll just remind you of the format for questions, sorry. If you do have questions, please reserve them to the end of the talk and then raise your hand using the raise hand icon in the participants participants button so that we can call on you. If you're having connection difficulties or what have you, also feel free to enter the question into the Q&A section, and time allowing, we'll read it to our audience and get an answer for you. So now without further ado, please join me in welcoming Professor Kirsten Bibbins-Domingo as today's UCCS Speaker Series speaker.
Thank you, Dr. Kravitz. I really appreciate the kind introduction and the opportunity to speak with this group today about this topic. So we're going to talk about the pandemic response, and the speaker series is really charged with thinking about the post-pandemic, and obviously these are topics that are interrelated, and I think hope to convince you both related to equity and how effective we will ultimately be in the remainder of the pandemic and what happens afterwards. So just to remind you, the inequities that we have experienced and witnessed during the pandemic, that the effects here of hospitalizations have not occurred equally or equitably across here, looking by race and ethnicity. And you can see higher rates in Black, Hispanic, Asian, American Indian. You can see the differences over time, and really highlighting the fact that even over time, as the rates have increased, the disparities have been quite striking there. The trick here, of course, is that this is not the current pandemic. This is the pandemic of 10 years ago. And those people who study pandemics, who implore us to prepare for pandemics, always highlight that the inequities that we see in the pandemic are always anticipated, that an infectious disease that wreaks havoc on the entire population will disproportionately wreak havoc on those most vulnerable, either because they don't have the resources, we need to work harder to reach them in a variety of ways related to access, because issues of where they work, where they live, who they interact with, what other access issues related to new technologies and treatments always disproportionately affect those who are most vulnerable. And we have to prepare for them. And what I hope to convince you is not only do we have to prepare for them because it is our responsibility, but our overall effectiveness depends on realizing that this fact is inevitable. I came to this, I'm a general internist, I'm not an infectious disease expert. I had thought at the start of the pandemic that I would really focus on my own work, on being a doctor. I practice at San Francisco General. But in reading about this, as somebody who thinks about health inequities and realizing that, that we knew that this was going to be almost inevitable, I wrote this piece very early on and hoped that this time would be different. I hoped, as well as I think many of us who think about health disparities all the time, that this time would be different because we live in such an interdependent environment. We are globally interdependent. We are locally interdependent. We were in the midst of an economic crisis at the same time. And that clearly the way to think about a highly infectious agent was going to have to be to understand our interdependentness, to think about the most vulnerable at the same time we were thinking about the overall response, and that both our crisis related to the infectious disease as well as our economic crisis would depend on our ability to do this. Of course, as you know, this time wasn't that different. How have we done? Because of my interest in this topic and many of those who I work with and around me, we decided to start looking at the data very early on. And we were really pleased to partner with the California Department of Public Health, who made the death record data available to us to look at who was dying during the pandemic and how do the deaths during the pandemic compare to the deaths that we anticipate that happened during here starting in 2020. You can see then the excess deaths being the difference between what we would have anticipated based on prior years and what actually happened in this year of the pandemic. So we decided to look at this by many of the characteristics on the death certificate. And the reason we look at death certificates, I should just say, is that it gets us around the differential diagnosis rate. People who die have died, and we're pretty confident of that. If you just look at COVID-specific other types of ways of looking at this, sometimes you miss those that might be COVID but not have been fully diagnosed with COVID. So that's why we focused on excess mortality. What you see here is what happened very early on in the pandemic. You know that for us as a state, we were a state that really had a strong early public health response in terms of the shelter in place. But even during this shelter in place, we saw these differences emerge. Black Californians had the highest per capita deaths early on in the pandemic and have been high throughout. You can see this best on the lower panel here. The dark bar here is Black Californians really strikingly high during those early months of shelter in place. What's true in Latino Californians is that while most other groups saw declines as the shelter in place proceeded on, Latino Californians never saw a decline. So that early and what is considered to be a highly effective intervention of the early shelter in place never really benefited Latino Californians from the excess deaths. Those death rates never went down, and in fact continued high during that wonderful period when we thought we could move into last summer free of this pandemic. What we saw was continued high and then strikingly higher rates among Latino Californians, who, as you are probably aware, account for more than 50% of the excess mortality overall during the pandemic, during the entire course. And we saw that pattern very early on. We're also able to look at this by other factors on the death certificate. And I think the opportunity here to think about education both important in and of itself and oftentimes a proxy for other things that we recognize as income or class. Education is the thing is measured on the death certificate. And the striking finding to us here is that 2/3 of the excess deaths in California adults have occurred in those who have only a high school degree or less. And this is across race and ethnicities. We're in the process of doing more recent work showing that this really is something that is strikingly across any other demographic group that you way of slicing this, that this really is another way and a critically important way to think about the disproportionate impact of the pandemic. We wanted to drill deeper for Latinos in California, given that they are our largest race and ethnic group and disproportionately affected in these excess deaths. It's not just being Latino in California, of course. These are higher excess mortality that really is disproportionately high amongst those who Latinos who are not born in the United States. And so you see here the information we have on the death certificates based on Mexico or Central America as the country of birth, compared here to those who are born in the US, where you see the excess, especially during our winter surge, or the end of the summer surge here, but as much strikingly higher among those who are foreign born. And when you try to put things together and you ask, what about being Latino, foreign born, and then which occupational sector they're in, you start to see how the multiplicities of these vulnerabilities really highlight who is dying during the pandemic. Here, comparing US born and foreign born, and then by occupational sector. So if you're in a non-essential sector, those who are foreign born really have an increased risk. But that if you're an essential worker really being defined by in-person work during a time when many of us have the luxury to work remotely, having strikingly higher risk here. This is work that Alicia Riley has done, who will be a new faculty member at UC Santa Cruz. And she's done really wonderful work for us throughout the pandemic. Here she's looking specifically at working age farm workers and the rise last summer in the excess mortality among working age farm workers during the summer months when we saw the most striking surge at that time in the San Joaquin Valley. Important to know, who are our farm workers? So 85% of working age farm workers who've died of COVID-19 have less than a high school education, and 69% have less than a 9th grade education. And even more importantly to realize is that the average working age farm worker who's died of COVID-19 has spent 24 years on the job. And these are people who have died, who have spent many, many years and decades really working in this critically important sector of the California economy, and have really been devastated. This community has been devastated really by the impacts of COVID-19. How do we think about what are the pathways that lead to this disproportionate impact, particularly in this group of the farm workers? These are low-wage workers, oftentimes, of course, doing in-person work, oftentimes unprotected by the things that we know can offer some protection in the workplace. a group with low formal schooling, as you've seen by those numbers, limited English proficiency. Probably the information I'd love to have most from all of the data we collect is who has a limited English proficiency so that we can reach most effectively. And then the additional issue of unauthorized legal status, which both affects agency and the ability to advocate within a workplace setting, as well as access to many of the types of relief that was offered federally, which many were not able to access. We've thought about essential work more broadly, and fortunately have made use of the codes that are on the death certificate. And this is work led by Yehung Chen, who's a PhD research analyst at UCSF. We were really encouraged to do this by many who've noted, either who are in public health or who are in other economics or other related sectors, how little information we have about occupation. We knew that essential work was likely to be an issue, but there's very little data. There's very little data that could be collected in real time, very little data that we had sort of writ large to really understand the health impacts of occupation. And this still is a gap. I think that is being addressed over time and luckily has been recognized, but still is a gap in our ability, I think, to really respond effectively. So we use the codes on the death certificate, not perfect, but codes that suggested, and we grouped these codes by the essential work sectors as defined in California. And here we are comparing just working age Californians, and we are comparing within sector to the death rates that you'd anticipate for working age Californians who work either in facilities or food and agriculture or manufacturing or travel and logistics. And what you see here is that if you worked in food and agriculture, you had a 39% increased risk of dying during the pandemic compared to your to the death rate that one normally observes for people who work in this sector. That is something that allows us to account for the fact that some of these sectors are inherently risky. They might actually at baseline have a higher risk of mortality, but really the strikingly higher rate for these particular sectors, essential sectors during the pandemic. We're able to drill down, and this is if we were able to try to think of how to target our response more, it'd be great to think about many of these dimensions together. We looked at this together and tried to think about race and ethnicity and our essential sectors, and there also I think was a lot that was revealing about how we might think about our response. So here what we're looking at is just to guide you, this is saying that working age Californians have a 22% increased risk of dying during the pandemic compared to the prior years. If you are in food and agriculture, you have a 39% increased risk of dying, and you can see the other sectors here. If you look across, you can look by race and ethnicity, and you can see here Latino Californians, 36% increased risk of dying, Black Californians, 28%, Asian Californians, 18%, white Californians, 6% higher compared to prior years. And then we looked across the different sectors where were people of these different racial and ethnic groups dying disproportionately. And strikingly here, of course, is Latino Californians working in the food and agriculture sector. And I think if you look at the number of workers in these sectors who are low-wage workers, you can see how these multiple types of disadvantage come together in a striking way. Food and agriculture here would include those working in the fields, those working in meat packing plants, and it would include those working in restaurants as well as some types of grocery stores. Among Black Californians, retail is the sector that is implicated when one looks at excess mortality. And one of the things that was very striking for us here is looking at Asian Californians. This is a group that has had lower rates of excess mortality compared to Black and Latino, but also our ability to understand the disproportionate impact is really hampered by the ways in which we group different communities within this under this rubric of Asian. And the thing here that I think was highlighted so strikingly was the disproportionate excess mortality in those who are working in the health-related sectors. Health-related sectors, of course, have, those are risky environments, but those are also environments where, generally speaking, there's a greater access to the ways in which we can protect ourselves in those environments, namely types of PPE. But this clearly wasn't something that was protecting Asian Californians, because this is a very broad and heterogeneous sector, right? And includes many who in the nursing fields, where we know Pacific Islander nurses are disproportionately represented, includes those working in a variety of types of settings, in home care settings and in other nursing home settings, and really highlights risk that you do not see unless you're able to really disaggregate that data and think about these things then in more intersectional types of ways. So looking at this and thinking towards the end of the summer with some of my colleagues, it was clear that California was really two Californians. There were people who had a very daily experience of the death and destruction, who knew people who died, who themselves knew that they were facing risk in their workplaces. And then there were many of us whose lives were disrupted during the pandemic, but didn't personally know people who had died. And this was even before the winter surge. But I think the fact that we were already so split going into the winter surge meant that we had two different perceptions of our public health response. We had two different perceptions of the overall risk. And really, I think, hampered our ability to move forward in the most productive way possible. And we see this even in a city like where I live in San Francisco, which overall has had a really I think a really excellent public health response, excellent in terms of control rates, even compared to many parts of the state that overall has been excellent. But even within San Francisco, the rates between the eastern side of the city and the western side of the city are tenfold different. And so there's two halves of California we see play out in my city, which is two halves of San Francisco. Why does this matter? It matters because much of our public policy is dictated by these average effects that we see. We look at average numbers of the case rates. We knew average numbers of the hospitalization rates. We set metrics based on where we think the cases are going or our hospitalization rates are going. But these averages in California and the averages across the country and the averages in San Francisco really hide these very disparate effects, that there are populations, there are parts of our community that are really affected and parts that are have had their lives disrupted, but really haven't experienced the dramatic impact of the pandemic. And this is the words of the Nobel laureate, Sir Angus Deaton, economist who writes about social issues and says averages have no consolation to those who've been left behind. So let's reflect. So throughout the pandemic, we have observed stark disparities, and these are deeply rooted in the pre-existing social and structural inequities. The disproportionate burden of COVID-19 on poor and minoritized communities was predictable. It was predicted, and it could have been and should have been planned for. And what I would like to argue is that our failure to focus on equity in our pandemic management has also, in fact, limited the overall effectiveness of our response. This is something that was recently highlighted in a great piece by Ed Young in The Atlantic, who I hope you have been reading throughout the pandemic and even before the pandemic, has really been wonderfully terrific at synthesizing both the science and the policy issues that are at the forefront. And here he's writing about how do we prepare for the next pandemic, because as much as we are still impacted by where we are right now, we already have to be planning for the next one. And this is an article that everyone needs to read. It came out, I think, 2 weeks ago. But here he highlights with this quote, including the quote from Mary Bassett, saying, "Inequity reduction is not a side quest of pandemic preparedness. It is arguably the central pillar, if not for moral reasons, then for basic epidemiological ones. Infectious diseases can spread from the vulnerable to the privileged. Our inequality makes me vulnerable." Mary Bassett, who studies health inequities at Harvard, now moving to New York City, told me, and that is not a necessary feature of our lives. It can be changed. And I think it's this final point that I'd urge all of us to think about as we talk about planning post-pandemic. So the equitable response, I want to argue, is also the effective response. So I'd want to focus a little bit on where the bright spots are. I've sort of highlighted where the inequities have been. In the bright spots, I'm going to focus on those things that are sort of in my purview. And I don't mean to say that the people I work with are the only bright spots in California. It's just that I can talk about them in a way to highlight, I think, those aspects that I know have been true in many other parts of California and really highlight where we should be focused. So this is one partnership that I would highlight, and it is a partnership that really was led by my colleagues, Diane Havlier, Karina Marquez, Gabe Chamey, physicians who worked at San Francisco General Hospital, who work with me there, and who, with me, saw that early on our hospital was full of mostly Latino patients in San Francisco, and wanted to really understand what we could do in order to help address this, what was clear from the outset, disproportionate impact. So this is a partnership with many of the businesses, the community leaders, mostly in the mission. This is the Latino Task Force. This is a partnership that has involved the departments of public health, the school board, and then, as you'll see, also many of our scientific colleagues as well, under this partnership called Unidos en Salud. So what their team realized early on was that we really just needed more data. And data is something that, as the University of California, this should be our sweet spot, right? Health and data is our sweet spot. And I think the strength of this partnership has been to see how our ability to work in partnership, in coalition with others, bringing what the universities bring and do best to community and to policy, I think has been the bright spot of this partnership. Here early on, wanting to understand in the census tract, in the mission, could we actually quantify how many people actually have COVID-19? Now this right today seems like, well, this is obvious how one would do this. Remember, we were in the midst of shelter in place, 6 weeks into shelter in place. Everyone was at home. And my colleagues here, got permission to be out on this census block, knocking on doors to try to get people to come out to be tested. This is a census tract that is 58% Latinx, lower income, about 4,000 people in this census tract. This work was done in partnership, in coalition with community partners. And the goal here was not just to gather data, but to think at all times in all of our responses about testing and responding, thinking about the needs, the deep needs that were happening in this community at the same time. And this has been, as you'll see, sort of our model for much of what we have done here. The test and respond means that the resources that oftentimes have come from philanthropy, from other types of resources, governmental resources, are reinvested in the community because it's the community members that are involved in the response, which is an additional and an important benefit as well. So what Dr. Havler and her team showed was that there was a high demand for testing. It's really striking to think at that time, over their 4 days of testing in the mission, that they tested about a third of all the tests that happened in San Francisco at that time. They highlighted that even though the census tract was about 58% Latino, that the positive cases were almost exclusively amongst Latinx residents and workers. Highlighted in the results that that most of those who were PCR positive reported no symptoms. This is something we take for granted now, but wasn't known at that time. And highlighted too that while we were told to work from home, that most of the positive cases were in those who could not work from home. And then in a wonderful partnership with the CZ BioHub and Joe DeRisi's lab has really been, who have been using genotyping to both document patterns of transmission, as well as now documenting also variants and the rise in variants, has really, I think, helped us to think not only about the types of data we collect here, but how these community partnerships can actually yield important data that inform lots of what we can do, both at the community level and at the policy level. So in that study in April of last year, 2% of the people who tested positive that lived or worked in the Mission Census Tract, these were positive 6 weeks into shelter in place. There were multiple strains. They were unevenly distributed in the community, and about half were asymptomatic who tested positive. And clearly they're showing low-wage Latinx community members unable to shelter in place, living in high-density housing, importantly, were also highly affected. But here, what I love is the work that Unidas and Salud has done has really, I think, led to tangible changes in policy, in how we have mobilized our public health response in San Francisco. So there was clearly a need for low barrier testing. People were willing to come out and be tested, but if we could reduce the barrier, that could help. That has led to the way we've thought about the testing sites. Showing that symptomatic testing was not sufficient led to a change in the testing criteria. Showing that loss of wages was a barrier to testing led to the right to recover legislation and the right to recover fund that provide replacement wages to those who were low wage workers who had to quarantine and therefore miss work. That job loss is a barrier to testing, I think, has heightened awareness about this, and which has been important, and then really has been a model for many outside of California, but also for us in the Bay Area. The Latino community isn't, of course, the only community affected. And I think one of the real thrills for me has been to work with many faculty at UCSF who've been thinking about different communities who are vulnerable in different ways during the pandemic. This is work of Dr. Kim Rhodes, who's really focused on the African American community and has led a coalition called Umoja Health. And the African American community is much smaller, very dispersed. She has worked mostly in the East Bay. The big testing sites, which Unidas and Salud has really championed and launched, she realized with her coalition wasn't really going to work in the most effective way to reach the communities she was trying to reach. So she's gone to pop-up models and has thought partnered and thought about how to use these pop-up models effectively to bring not only testing for COVID-19, but also testing for many other, both testing for other conditions as well as registrations for other types of social services to the communities and that she is partnering with. Dr. Margaret Kuchel, whose work I'm not going to talk about, has been really instrumental in using the same types of approaches to thinking about testing for those in the Tenderloin, those who are marginally housed and in living in areas that have a high density of marginally housed individuals. So All of these types of testing that we have done and that we're proud to have done have really had their own flavors. They've really been unique to the communities that we are working in partnership with. But we have realized that they have been both powerful and necessary, and they have many common features. And we've been really fortunate to learn from one another in how to design these. And this is work that our community partners, our public health partners, and our academic partners have contributed to highlight the importance of this. That it was important that this was coalition and ultimately community led. The community voices are the leading voices in these coalitions. These are very focused on testing, and what you'll see is vaccinations, but mostly about the types of services around those things as well, because recognizing that we are not just trying to deal with the pandemic, we are trying to deal with the deep needs that are in these communities that really exacerbate the issues of the pandemic, but themselves also need to be addressed. They're very much about data and the data to inform public health, the data to empower communities for advocacy, as well as, frankly, we're also learning things that have helped those of us who are thinking about scholarship in this area. These are coalitions and initiatives that need to have trust to work. That trust doesn't come easy. I remember the first meeting I participated in. I remember when we had our second meeting, there were several community members and one person in the Department of Public Health who said, "I can't believe you're having a second meeting after that first meeting. After all that yelling, I didn't think a second meeting was possible." But I think what was important in the pandemic was both the urgency and the willingness to, I think, to just stick with it in some of these things that have allowed us, not always easily, to solidify partnerships that we hope will be partnerships for the future. What are the things from the local level that can then be amplified and reinforced on the statewide level? And here is where I really, I think we should really highlight and be proud of California highlighting the sort of measurement and accountability of equity in the way it's thought about the response. So California launched a health equity metric focused on disparities in COVID-19 impact. This is to get at that issue of average effects that were really driving how we thought about the county's risk level, how we thought about the metrics for reopening. Again, those average effects oftentimes hide the fact that there are still communities where the virus is spreading that really have been disproportionately impacted. And the equity metric basically said, it's fine for you to move through these different tiers, but unless those who have been most affected in your community also have some benefit, or at least moving in that direction, you can't move to the next step, right? And so you'll remember when these were opened that then counties who were set to open but fell short on the equity metric couldn't open. And what this did, I think, was to really both focus the efforts which were going on in the county. Much of these types of public health efforts that I've already talked about that were happening in San Francisco, but also in many other counties across the state, but actually reinforced that those efforts were going to be important, that those efforts needed to be resourced and prioritized, needed to involve the multiple stakeholders if we were as a county then going to move forward. And I think that that this is the type of thing that we need in a whole variety of settings, is not only to prioritize equity, but also to think about how to create the metrics and accountability to do that. I have really been thrilled to work with many in the Department of Public Health in California to think how we can connect more closely on these issues, particularly as they relate to data. And this is something that we launched at the start of this year. UC Health across all of our UC campuses and the California Department of Public Health, thinking together about how one models the data during the pandemic, how one thinks conceptually about the public health problems so that one can then apply the analytic tools in the best possible way. And then really having the opportunity, I think many of us on the academic side, we work but we have no idea what our colleagues in public health are actually the question that is most important to them. I think one of the most important things about this particular consortium has been the opportunity on a twice monthly basis to come together and to both share information, presentations, and really to hear from each other about the most pressing issues of the time. And it's something that I hope will continue to grow and hopefully grow into being more of a model for more ways we might address and work together across public health issues. This is the data from the paper that Ye-Hung Chen led on excess mortality by employment. Here he published actually the specific occupations that had the highest cause of death, excess mortality, the highest excess mortality during the pandemic. Cooks, machine operators, agricultural workers, bakers, construction laborers. I remember when he called me and he said, I'm going to post this on the preprint server because I think we just need to get this data out. I said, okay. And this was something that actually got picked up quite a bit. And I think it's now published in the peer review literature, but I think provided information through the preprint server in a timely way at a point in the pandemic when we were all trying to think about how to address the issues in the most data-driven way possible. And I think California has always tried to do this. Oftentimes the data is not fully there. But I think when the data is there, I think moving policy to align with where the data are has been important. And I think that you see this both in our statewide responses as well as the national response, that, for example, food and agriculture is a sector that is recognized because of this work, and as well as many others who've highlighted this, not only with what we theoretically realize, but what we through data can show is really a strikingly high risk. I think this has highlighted how we prioritize our vaccination efforts, and even now in the Biden administration, how we highlight those types of financial compensation and response to those really who have borne the brunt because of the hard work that they're doing in these essential sectors. We've been big advocates of taking vaccine to where the virus is, to thinking about the vaccines in terms of geographic areas that have been hardest hit by the pandemic, but also because of the other infrastructure and factors related to health within those census tracts or other geographic areas we know will be more vulnerable. It turns out that geographic approaches make a lot of sense when you model them. They make a lot of sense not only for California, but for most places that actually start to look at this. This is work that I've done with colleagues at Minnesota, where we look at comparing age-based strategies for vaccination distribution to geographic strategies, and showing that when you only do age alone, you miss the opportunity to really focus on communities that we know are hard hit, but oftentimes skew in a younger age. And geographic targeting, geographic prioritization, which California also initiated in its vaccine rollout, I think is an important strategy to use when one is thinking about equity. We see this in San Francisco, of course, again, that I will just highlight because I know this data the best. This is work from our clinical enterprise here, the San Francisco Health Network, really showing how their distribution of vaccines really related to where the COVID cases were. And they really prioritized by zip code and actually achieved that prioritization in the way when you see the communities that actually got the vaccines early on. on when these were much more limited. Our community-based efforts at testing translated and transitioned to vaccination efforts as well. This is Unidos en Salud and the line to get the vaccination. And of course, we're really proud in San Francisco that the vaccination rates, if you look in the Latino community that really has been disproportionately hit in San Francisco, has amongst the highest vaccination rates in our city. Across the state, we haven't achieved this high rate across all Latino communities, but we have had efforts focused on reaching Latinos. And I'm pleased to say, we just submitted a paper today showing that the disparities in mortality rates, the disproportionate impact in Latinos in California, you can see that change has happened. And that is to a large extent because of a lot of this very focused community outreach. There's still more work to do. This is the state's vaccine equity metric. So looking at how effective are we at distributing vaccines by by places that, because of the types of businesses in those places, the types of other health promoting or health detracting environments in these locations are either considered more healthy or less healthy. This is for the Healthy Places Index, and showing that we have been best at those places that are the healthiest because of the other structural and social environments, and least effective, unfortunately, at those those least healthy places. But I think even there, you'll see that this uptick, I think, has reflected some of the continued efforts to make sure that we increase our effectiveness in those places. We also know we have more work to do here. When you look at those areas in green that have high vaccination rates and low hospitalization rates, we see that that is true in lots of California, but we have plenty of purple in California that have low vaccination rates and high hospitalization rates. So much more to do. So what is true about the elements of an equitable pandemic response? Again, highlighting those that I know the best, but I want to highlight these elements that I think are universal. First, the recognition that equity is a moral imperative and is critical to effectiveness. This isn't something we do on the side, but is front and center. That partnerships are critical. I've highlighted the community partnerships, but also the multi-sector coalitions. And these, I think, are going to be important as we think about our post-pandemic response. And I think because we are here as an academic institution, I think the academic public health partnership is one that I hope will continue to be strengthened. Data to inform policy. The data needs are so deep and have remained throughout the pandemic. And you see the power of having data to inform policy. And I think we will only see that more. And then importantly, and here's where I think California really has been a leader, is in the metrics and accountability, being willing to say that this is important, we're going to measure it, and we're going to have strategies to hold people accountable. So this time was not different, but I think there are lessons that we can learn from this. And it's important to remember that these are things that we have been dealing with in public health for a long time. And this is the words of Rudolf Virchow from 1800, thinking about the typhus epidemic, that the answer to the question as to how to prevent future outbreaks is quite simple. Education, together with its daughters, freedom and welfare. However, in practice, it is much more difficult to see how this social problem is solved. Let us be perfectly clear. We are confronting the fundamental problem of attempting to understand those factors which has made us what we are and which will determine our future. So those are the words I'll leave you with as you think about planning for post-pandemic, and I'm happy to answer questions or have a discussion.
Wonderful. Thank you so much, Dr. Bibbins-Domingo, for just a fantastic talk today. And I'm just going to give Brooke just a minute here to go ahead and stop our recording.